Welcome to PEM CHATT. This is a peer-to-peer educational podcast about pediatric emergency medicine for the advanced practice provider. My name is Toni. I am a family and emergency nurse practitioner in Chattanooga, Tennessee, and I will be your host. All right. Well, hey, PEM CHATT listeners. I'm glad you're here with us today. We are back today to talk about DKA with Dr. Whitney Buss. We've all probably heard that age-old med school little saying, right? When you hear hooves, think about horses, and don't chase zebras. But I'm here to tell you that Dr. Buss is a zebra herder. I think she lives on a zebra farm, which is truly a compliment. You're one of the most intelligent and brilliant people I've ever met. So I'm glad you're here with me today.
Everyone listening, please lower your expectations.
Not even. Well, I couldn't think of a more perfect person to have on the podcast today to talk about diabetes and DKA than you, because you are a type 1 diabetic.
That's correct.
Have you experienced DKA?
I think so. I say not convincingly because I was never on any drips, and I think I corrected at home, but I was in middle school. I had a pump failure and I felt horrible. And my glucose was super high. I was vomiting. So ultimately, my parents were out of town. It was a very chaotic encounter. But I think I treated myself, which is not what you're supposed to do. But other than that, I haven't. I've been very fortunate to not have had to experience it.
You've
that
been
I'm aware
a doctor since you were diagnosed with diabetes, I guess.
Yeah, more or less. My own doctor of some sort. Yeah.
How old were you converting yourself at home?
When I treated my probably DKA, I think I was in like the 8th grade.
Wow. That's crazy.
Yeah. But I've had diabetes since before I turned 2, which is pretty young. And so I just credit my parents for, instilling in me and, setting me up for success because, right, I wasn't managing in it too. So that's all my parents. So, yeah.
Well, before we get started, tell us a little bit about you.
Yeah. Okay. So I am currently a PEM doctor in Chattanooga with you, work in Chattanooga. And I came to PCR by way of pediatrics. And I did my peds residency in Vermont. And then I did my fellowship in Austin, Texas, and then came to Chattanooga. And I grew up in Georgia. So I've kind of been mostly around the eastern side of the U.S. And I've been here now for probably 5 or so years and still learning.
And you're
still
learning,
and I'm going to stay. Chattanooga's home for me. And so, yeah, I love it.
What's your favorite thing to treat in the ER?
I do really like DKA, but I love patellar knee dislocations. That's probably one of my favorite, except for the time I tried to correct what was a fracture. So,
I was there.
We all make mistakes. Yeah, we all make mistakes.
Oops.
Yeah.
All right. Well, let's get started on DKA. I think, we see 2 versions of this in the ER. We see our kids that come in with new onset, and then we have known diabetics that come in with DKA. But we thought we'd start, kind of talking a little bit about new onset. One of the things I read about last night is there's some statistics that show us that in new onset diabetics, 34% of those kids were actually seen somewhere within that last week. So, somewhere along the way, we missed that. And 39% of kids that show up to the ER and DKA were also seen somewhere earlier that week. So something to kind of keep in mind when you're seeing kids. What do you have anything to add about that?
Yes, I think, the younger the child is, the harder it is because they're not going to tell you, they're not going to disclose all this stuff. So you have to be kind of astute and paying attention to these subtleties. And early on, it may not be very impressive, right? When their body stops making insulin, it's not going to be automatic that you're going to notice, oh, they're so thirsty. And the family says they have lost 20 pounds. Early on, they're just going to think maybe little Timmy's going through a growth spurt. He's eating a lot and he's looking lanky, but they're attributing that to like he's growing taller. He's thinning out. And so I would say just the guardian is going to know them best. And if they say he's drinking a lot of water or he's peeing a lot, something that seems really subtle when this kid looks really good running around the room, it's pretty easy to get a glucose. It's a pretty easy test, or to check a urine. And so I would just have a high index of suspicion early on.
Yeah.
Because it's subtle.
Yeah. And in kids, I was reading that type 2 diabetes, you can present in DKA in kids, which is kind of unique to, well, I guess it's not completely unique to children, but more likely to happen in children than adults. Have you seen much of that?
Yeah. I have not. I think anytime I've seen someone in DKA, regardless of if it's going to be type 1 or type 2, it doesn't necessarily change what I do in the ER. I think that probably affects how the endocrinologist will end up managing them. Now, so it hasn't changed what I've done. I've still ordered like all of my baseline labs, but I do think, right, our patient population is changing. And so we're just going to have to be mindful of seeing classically adult pathology in pediatric patients and be prepared with how to manage that.
Yeah. And, I came from pregnant land, and in pregnancy, we saw that too. So it was kind of interesting that kids and pregnant women share that. There's something
kind
later.
Of overlap.
Yeah, there's a little overlap in another part of this topic later. What's the most common age group that presents with new onset?
I think it's bimodal. I think it's like 4 to 6, and then you see it again in adolescence. And so 11, maybe to 16. There's a subset of people that will be diagnosed with juvenile onset or type 1 as adults, but the majority, I think 75%, are diagnosed as children. And 2 or 4 to 6, that's a little bit easier, but I myself was diagnosed when I was much younger. And so the younger the child is, the harder it is to diagnose, which means they're more likely to be in a more significant degree of, insulin deficit. And so they're more likely to present in DKA the younger they are.
Mm-hmm. Yeah. So let's talk about a case, something that you saw that'll kind of help us through like how we kind of initially approach this patient, what the exam looks like, kind of what you're thinking as you're building your differential.
Okay. Yeah. So I'll talk about this little case. We'll call this little girl Susie. She was 18 months old, and she came in for trouble breathing. I will say it is winter time. So this could be December through February, which is pretty common for us to see respiratory complaints, right? Mm-hmm. Pre-pandemic, this is like classic for bronchiolitis or pneumonia or influenza. So respiratory complaints are not out of the ordinary. And she's a high level acuity, and mostly for her respiratory rate. So you walk in and you get information from Susie's family, and they're telling you that this is their third ER visit. She was diagnosed with croup the night before. She got a dose of steroids and a breathing treatment, and they sent her home. And you're not hearing stridor. You're noticing that she's tachypnic, and you can see some retractions, but when you're listening, you don't really hear wheezes. But she looks like she's in distress. There's no oxygen requirement. And so you leave the room and you think to yourself, well, it's probably bronchiolitis. I should suction. And you try that and there's no improvement. And you keep assessing and assessing. And you think to yourself, well, she probably needs some respiratory support. And you say, I'm going to get a blood gas before I do that. And you get a blood gas and she's acidotic, pH of 6.9. The CO2 is quite low. You're seeing a CO2 of 8, which goes against what you're expecting from a respiratory standpoint. And then you get a glucose and it's 400. And you kick yourself in the foot because you almost intubate her, which is not what you're supposed to do. And you realize, oh my gosh, this girl's Kussmaul breathing. And I never heard wheezes. I never heard crackles. So I should trust my physical exam. But you weren't paying attention because you were so fixated on the chief complaint. And that was a case for me in fellowship as someone that has diabetes. And I was just so focused on what the family was saying, and that in the past 3 days, they were really focused on her breathing. But then when you can go back in and have this information and ask, well, hey, do you think Susie has been more thirsty? They're always like, oh yeah, I'm constantly refilling her sippy cup. Or has she been peeing more than normal? It's like, oh my gosh, she's soaking her overnight diapers and like it's getting the whole crib wet. And she used to not do that. You get this information that the family didn't know was relevant. And that was a huge moment for me because I just almost did the same thing as, another provider had done with her. And I was like, just not paying attention to what was right in front of me.
So easy to do in the middle of viral season.
100% in the middle of winter,
Yeah.
and I think that's our greatest fear as providers, that common things are common, right? Common things are common, and you're most likely going to see common things, but you should pay attention to the subtle differences that don't make sense. And it's helpful to have more information.
Yeah.
And oftentimes too, we're busy in winter, and so we may not feel like we have the time to get more history, or it's hard to get history when the family is really panicked about what their daughter looks like in front of you, right? And so sometimes it can be helpful to get some basic points of information, like a glucose and a blood gas. And it does not have to be an ABG. I think when I'm talking to referral centers a lot, they feel like they need to go stick and do an ART stick, and it does not need to be an ART stick. It can be a cap, a finger poke. That's all. You don't have to really torture this child to get more information.
Yeah, I think in medicine in general, people are veering away from ABGs unless you're intubated and you have an ART line and they can easily access the sample. Pretty much everywhere, even in the adult side, we were doing VBGs on almost everybody.
Good.
So one interesting thing to think about with DKA is a symptom, right? We need to be looking for the underlying pathology. Let's talk a little bit about that.
Yeah. So if you think about the role of insulin is meant to allow us to absorb and use glucose. And that's what our body wants to use as an energy source. It's its favorite energy source. Your brain is jealous and wants glucose. It does not like fasting states. And so insulin allows absorption into the cells. In type 1 diabetes, you have a destruction of beta cells, which are in your pancreas. You have other cells in your pancreas. So just because your beta cells are attacked does not mean your pancreas as a whole is not working. Okay, so it's not like the whole organ has died. You're just no longer secreting this, which is used for glucose regulation, essentially. And when you do not allow insulin to absorb glucose into the cells are looking for another energy source. And the body has creative ways of coming up with ways to deal with these periods of stress. So they will destroy protein, muscle, fat, and the byproducts of that can create acid. You'll see this weight loss because fat stores are being depleted. And the byproduct of that acid is going to decrease your pH. And so it is DKA for these new onset is kind of this gradual process because all of their beta cells usually aren't destroyed in one fell swoop. They still have some mild insulin secretion. And so it's not like just a flip of a switch one day that all of a sudden it's evident. It's a little bit gradual at first. And so when you have glucose that's building up in your bloodstream, your body does not like anything that is out of equilibrium. And so when you have a glucose building up, your body's going to come up with ways to get rid of it since it can't use insulin to absorb it. And so you start to pee it out and you're triggered to urinate it out. I probably shouldn't have said pee on a podcast. I don't know. Drink water. You have this hyperosmolar state. So drink water. And so your body is trying to regulate. So it's encouraging you to drink, then your body's encouraging you to eat because it wants an energy source. So that's why you see these kids are voracious and they're thirsty, and the families will say they were eating all the time but still losing weight. It's because they're not absorbing it. So then they're peeing all the time, urinating all the time, voiding all the time, whatever is the most correct way to say that. And just going back to when you're young, kids in diapers, it's hard to tell how often they're urinating, right? So that's why it's something that it's a subtlety that gets missed, and usually they're not able to get their own drink. Usually they're dependent on their caregiver, and so you don't see someone waking up out of their crib in the middle of the night going into the kitchen to get a glass of water versus a 7-year-old may get out of bed and go drink water. And so that's why these little things that in older kids are more obvious to see, it's harder to recognize in a young child.
Yeah. Do you find with new onset, there's like a trigger, like an illness, like we see in our chronic diabetics that come in with DKA?
Yeah. So there is, it's an autoimmune process. And so there are a lot of thoughts that it's typically triggered by some viral illness. And I think there's going to be data that comes out that shows COVID during the pandemic led to the onset of new onset diabetes or an uptick. Now, these individuals are most likely have a genetic predisposition, and so it could have been just a matter of time. But there typically is an inciting event that sets up these children. And you can, it's recall bias, but you can always ask the family, and I find it interesting, so I always will. Were they sick in the past month or so? Can you remember anything? And sometimes they can and sometimes they can't. But yeah, there is usually something. And just like with DKA, right, there's some stressful, usually inciting event that leads them into a more insulin resistant phase, which means they need more insulin, whether that's naturally, which is not possible for someone with type 1 diabetes, or they need to take more from an insulin administration standpoint.
Mm-hmm. Get it exogenously.
Yeah.
So what's our workup look like when we're going to start working this up? We suspect this may be that, or maybe we don't, but how do you approach the workup for this kid?
Sure. So I would say the first thing after you look at your vital signs and you've assessed them, usually these kids will look dry. And so they may be tachycardic. Their mucous membranes may look dry. That's usually pretty apparent. So most likely you're going to feel like you're going to need to get a line. And so I would just, when you get a line and stick them, I would plan on getting a blood gas, getting a BMP, getting a urine, because you also want to look to see what if they're spilling ketones, which I would expect they're spilling ketones if they look as bad as they look, right? And then I would send an A1C. Most hospitals have the ability to run A1Cs pretty quickly, and that can give you an idea of how chronic or how long-standing this has been. And that can also be helpful, in these kids that maybe have gotten steroids and you're not sure, is this new onset diabetes? Is it not? Their blood sugar's a little bit elevated, but they're not that tachypnic, and you can't tell, is this just a respiratory illness? Send the A1C, because if their glucose is 200, that can help you decide, okay, that was just the steroids they got yesterday. They're not in DKA. This is just bronchiolitis, right? Mm-hmm. And so the A1C can be very helpful. And then there's a slew of labs to get in a new onset diabetes standpoint that can be helpful for the endocrinologist later on. And I think that's like an insulin level and antibody levels, thyroid studies.
It's a long list.
It's a long list, and it doesn't affect your management right now. So it's not the end of the world if you don't get it. But if you're going to refer someone, it is helpful to ask them, is there anything that would be helpful before you give them insulin? Yeah. Because that's the important question.
And we work at a big center, so we have all this stuff available to us kind of on a protocol that's kind of a preset for our new onset, and that's based on what our endocrinology team prefers to get. So, if you're at an outside facility and you're trying to work this up, I would say certainly consult with a peds endocrinologist or your pediatric center that you're going to transfer to, and they can give you some guidance there. So just to be clear, so we're going to get an IV. We're going to get that VBG so that we can look at their pH. That'll probably give us some of our electrolytes as well. You mentioned a BMP. We want a MAG and FOS because all of that's relevant when we're working up somebody with diabetes. An EKG, do you routinely get that?
I think it's going to be helpful if you're not sure what's going on and if their potassium is abnormal, which it most likely will be abnormal in some standpoint. At some point. So it can be helpful. I don't think it's necessary.
Yeah. And what I read is, if they have really significant electrolyte derangements, you would want to get an EKG for sure. And getting the EKG early, even before you have the labs, might actually give you some idea if they're going to have a crazy potassium level. We talked about the A1C, a UA, and then the only other thing I have here on my list is a CMP. For a kid that I know is diabetic, I usually just get a blood glucose, a urine, and an iStat, and then kind of see what that looks like, and then I start doing the rest of that stuff. Do you do that as well?
Yeah. Okay. And I will tell you, like in a known diabetic that comes in, I almost always will get a blood gas, even if their glucose is not too elevated, unless they're coming to the emergency room for something that is just like a splint check or, But if they're coming in and they've had any nausea or vomiting, sure, they could have a stomach bug, but I almost always will get a blood gas because it gives me more information about their acid-base status.
Mm-hmm.
And just because they're hyperglycemic doesn't mean they're in DKA, but it's just going to give you more information to manage them appropriately.
Yeah, I like that idea because, you not only that, but there's sugars on there too, so you can just kind of get it all
Exactly.
in one fell swoop. I think that's a great idea. So in this population, is there anybody that I need to get a head CT on?
I would say if they are interacting with you, they open their eyes, they follow commands, I would not do it. Now, if the family is instead they're presenting late and they're very altered, then yes, because you're not going to be convinced that their altered mental status is just because of DKA if it's not known that they're diabetic. Or let's say you have a known diabetic that you're like, they look bad, they're in DKA, and then they decompensate, you are going to get a CT then, but you're going to try to acutely manage their decompensation quickly by trying to manage what you think is cerebral edema, right? Mm-hmm. And so you're probably going to give hypertonic saline or mannitol. I usually would do hypertonic saline personally only because they're usually already so volume down that the thought of giving them a diuretic just seems counterintuitive to me. But I think there's a lot of debate, and so no one's going to fault you if you did mannitol over hypertonic saline. But you then are going to be working on their mental status and managing their airway while you're trying to get your CT.
Yeah. So really kind of what goes for most things, like if we have altered mental status, we're going to get a CT, but otherwise we can kind of defer that because we probably don't need that, routinely.
Right.
And we're going to talk about more about cerebral edema here in the future, in just a few short minutes. So just for definition purposes, in case somebody likes numbers, what is the diagnostic criteria for DKA when we're looking at our labs?
You need to be acidotic. You need a low pH, a low bicarb, and a high blood sugar.
Yeah.
Is that basic enough?
pH less than 7.3, bicarb less than 18, blood glucose greater than 200, or 3+ ketones on your urinalysis. There's some additional definitions out there if you want to define mild DKA versus severe DKA, which is more about kind of driven by the pH. Mild being 7.2 to 7.29, and then severe less than 7.2. We can't talk about DKA without talking about HHS. And I had to write this name down so I could remember what it is. You want to tell me?
Yeah, you tell me. It's like hypernatremic, hyperosmotic,
hyperglycemic,
hyperglycemic, hypernatremic,
hyperglycemic, hyperosmolar state. Which I, honestly, before reading about this, is not something that I think about very often, but as I read more about it, I kind of got the impression that this kind of goes together like syncope seizure, we should kind of really be thinking about this, especially with a new onset if we don't know what's going on with this hyperglycemic kid. What's your experience with HHS?
Yeah, I think that it's something that we're going to see more of. It's more common in adults and in type 2 diabetics, and I was reading about the pathophysiology of it, and essentially, usually in these presentations, there is enough insulin circulating to prevent your body from, using alternative energy sources like we talk about when DKA. And so you don't get that acidosis buildup because there's enough insulin around, but not enough to actually deal with the hyperglycemia. Mm-hmm. And that would make sense if you think about type 2 diabetics who just have, for the most part, increased insulin resistance and aren't secreting enough. And it's not that it can't happen in type 1 diabetics, but usually the crisis there is that there's nothing circulating.
Yeah. So your pH, you're not as low. So usually, and this is just, kind of textbook answers, but, you're 7.3 or greater, super high glucose.
Super high. I think over 1,000. And you will see new onset type 1 diabetics and DKA whose glucose is around 700, but it would be pretty rare for it to be over 1,000. Not that it can't be, but that would make you think more HHS. And I've never seen HHS in a child under 12. Not that it couldn't happen. I just think you're more likely to see that in your adolescent patients.
Yeah, we had one recently. Do you remember how old that kid was?
I don't.
Yeah, I don't either. I think 9 or 10.
Like a teenager? 9 or 10.
I think it was pretty young, but I could be wrong. We'll have to ask Eli about that. They're going to make less ketones, so you're not going to have that gross ketonuria that we're going to see in our
Right.
DKA patients. And then this is where your serum osmosis is going to kind of be part of your diagnostic criteria here, and that's going to be elevated, so greater than 320 in those kids. Can you be euglycemic and be in DKA?
Yes, which is confusing because we just said you need those three
Right.
things to diagnose DKA, but there is like a state of euglycemic diabetic ketoacidosis. And I don't fully understand the phenomenon, and I don't exactly understand if it's just because you're getting maybe small aliquots of insulin and then your pump fails, or you're in a more insulin resistant state, or you did a correction and so your glucose is corrected, but you're still acidotic. And I think that's probably more likely, and that's maybe what I did when I treated my own DKA. Essentially, that's why I kind of recommend just getting a blood gas on all diabetics that are coming in that have had if they have any signs that go along with DKA, like nausea, vomiting, abdominal pain. And that's all from the ketones that usually makes you feel that horrible. And so you should look for it.
Yeah, if you've ever had the keto flu because you decided to eat keto, I guess it's like a little tiny taste of what it's like. You're like, no, that's not even close.
That's so funny. Yeah, and everyone's diabetic supplies, their ketone strips were, hard to obtain because of this keto fad. But
well, we'll try to stop stealing all your ketone strips. I couldn't remember to pee on the stupid stick. I had them for a while, but yeah, this is where there's some interesting crossover with pregnancy as well. So you can present euglycemic and be in DKA in pregnancy, and we would get a beta hydroxybutyrate, and if that was positive but her sugar was normal, then we would treat her for DKA.
You would still treat.
Kind of an interesting similarity between pregnancy and kids again. Yeah. Okay, so how do we treat DKA? What's our approach to fixing this?
Yeah, so again, you're recognizing that in general, this is not something that just happened so quickly. So you have to prepare that your management of it will not be immediate either. It's not just like you give a one-time shot and you've solved it. You have to recognize what happened to get them there. And so if they're a known diabetic and they come in, you want them to remove their insulin pump. Because most likely there could be a site failure. And so you want them to remove that because you don't want them getting insulin if it's somehow still working and you are also giving them insulin. I think it's okay for them to leave their sensor on. And it's okay if you don't know which is which. Your patient or their family should know, right? The sensor is going to be really small. And they'll tell you they can leave it on for like a week versus their insulin pump is something that they're going to change every 3 days. And there's usually tubing to the insulin pump, or they're on an Omnipod and it's bigger than the sensor. So one, I would just ask them, and then you're going to give them,
just a question. So the sensor you're talking about the sensor that's part of the insulin pump.
There's a lot of technology out there, and there are insulin pumps that will communicate with their sensor, but they're usually on the body in 2 separate sites. And so you need to have them remove the insulin pump or disconnect or suspend, and they should know how to do that. Someone hopefully with them knows how to control their insulin pump. They have something that controls it, or there's a home screen on it. But the sensor can stay on. And if their sensor is accurate, you can use that to see like what their glucose is doing and how they're responding.
I'm not sure I knew that. I kind of thought in my head, if you have a pump, you have a Dexcom or a Libre Freestyle or whatever, some kind of continuous glucose monitor. But the pump can't work if it doesn't know your glucose. So it's got to have a sensor for your glucose. Is that what is that? So
no, what you're saying is, so some technology, it's moving quickly, and a lot of pumps have created interfaces so that way their insulin pump can obtain information from their sensor, like their Dexcom or their Libre. But some do not interact. And sometimes you have to look at your sensor to say, my glucose is 175. And then you put that number into your pump. And then your pump has the programming in there to say, oh, I take this many units for 45 mgs per deciliter over my target glucose. And so using the algorithm that's in your pump, it will do that. But not all communicate with each other.
Okay.
If that makes sense.
That makes sense. So we're just moving along, and technology it's going to become.
We're finally catching up. And if you talk to a lot of people with diabetes, they would say it's pretty frustrating how slow it's been. I mean, we've got self-driving cars, right? So we finally have insulin pumps that communicate with each other is huge.
Yeah. I mean, why can't it figure it out? It can figure out everything else. I don't know why.
Right. Come on, AI.
Yeah. And you say, I appreciate when you say, we're not going to correct this quickly. I think,
right.
When I was a new provider and I'd get a kid in DKA, I just kind of wanted to jump in and like do everything right then and like order it all and get it all done. And like I needed to intervene in the first 5 seconds they got there. But in reality, it's a little bit of a more nuanced and slower approach, a more gentle approach, if you will.
A more gentle. Your patient is probably going to be super thirsty and they're going to be asking to drink and they're going to be very adamant about that. And that is just their body's in survival, right? They have an elevated blood sugar. Their sodium is out of whack. They feel horrible and all they want to do is drink. And so if their mental status is okay, you can let them have ice chips. But really the biggest first step for you after you recognize they're in DKA is to give them fluids. And you're going to give them a fluid bolus and you're not going to give a huge amount. In young children, we just do about 10 cc's per kilo. And we hold there because we're going to slowly give fluid back and slowly correct these electrolyte derangements that they've come in with. But that's the first thing you can do is once you get the line, you had the labs, is to give them a fluid bolus.
Do you ever correct their electrolytes before you give insulin?
I don't, because you're about to have electrolyte changes, and so if you go back in time to when you were learning at the cellular level, like how there was cell transport, we're exchanging potassium ions for hydrogen ions, right? And so in an effort to deal with the acidosis, our cells are pushing potassium out of the cells and bringing hydrogen in because we're trying to normalize everything, right? And so you're really not hyperkalemic. You may look like that initially, but as soon as you start to replace what's missing, you're going to have fluid shifts, cellular electrolyte shifts again. I guess the only time you would do something would be if they have really significant hyperkalemia from an extracellular standpoint and they're having cardiac changes on your EKG, then you're going to stabilize the myocardium and give calcium. But that's
insulin and
the
glucose
only situation.
Is part of that treatment anyway.
Right, exactly.
Yeah, great advice. Okay, so we start with the fluid bolus, and when do we consider insulin? When do we start insulin?
So I think you would start it. You want to go ahead and order your insulin drip, but it usually starts after the fluid bolus goes. But I would say in general, it does take a while for the insulin drip bag to be manufactured. So you want to order it then, but your expectation is the fluid bolus goes in, because the insulin is also going to work better. It's going to get absorbed better as you're perfusing tissue, and it's going to be able to get to, I guess, all different parts of your body that have glucose building up in it. I would say in the pediatric world, we don't usually give a slug of insulin to correct. So even if the family comes in and maybe their child's never been in DKA before, maybe their child was diagnosed before they were in DKA. They've never been in DKA before. They're in DKA now. The family may be really eager to help their child, right? The parents may come in and be like, let me just correct their blood sugar right now and give a huge slug. But you don't want to do that. And we don't do that because it's going to create too quick of a change. And so we don't give an insulin bolus. And we use regular insulin through the drip, and we just correct it slowly because the body's been compensating slowly.
Yeah, more likely to get more acidotic if you just give them a big bolus. And that's definitely different from adults as well, because we'll tend to give like 10 units or something on the
10 units, yeah. Get the ball rolling, sure.
Yeah. Okay. And we use a 2-bag system for fluids. Talk a little bit about what that looks like and why we like to do it that way.
Yeah, so essentially what's going to happen where you are or where you're sending the patient you're seeing is we're going to correct the glucose slowly. And we're going to provide them with fluids, and we're going to have potassium and phosphorus. Usually it's like K-phos and K-acetate mixed in to replete the body and what the body has been missing. And so typically when they come in, they're going to be hyperglycemic and acidotic. You gave the fluid bolus and you start on this insulin drip. It's usually like 0.1 units per kilo per hour. Yeah, I think that sounds right. And you're going to start them on this weight-based dose. And usually you'll start them on the bag that has normal saline in it. You won't have any dextrose in it. But as their blood sugar is coming down, you're going to start to give them dextrose back. This will allow you to continue to give insulin because you still have acidosis that you need to correct. And I think that's what's really confusing for people is, why are we giving sugar to someone when they come in with their sugar being elevated? But we need to be able to continue to give them insulin and correct the acidosis. And then we can worry about the hyperglycemia. But without dextrose on board, if their blood sugar falls too quickly, you're going to create more problems for the patient. And so typically each hospital is different, but when the glucose gets into the 200s is when you start to add the other bag of fluids, and you'll usually do like 75% of one bag and 25% of the other bag and 50 and 50. And there's usually algorithms based on where their blood sugar is headed and where it's been. And you're checking blood sugars every hour and you're doing neuro checks every hour because you're trying to monitor for how the body is compensating and reacting to what you're doing, the intervention you're providing.
Yeah. So, and if you are curious about what this two-bag system looks like, I will attach something to the podcast that shows you kind of a protocol of what that looks like. And you can always call your pharmacist. They can help you do that. They help us with all these patients at our facility. And so they'll help you kind of mix this up and get the right combination of electrolytes and sugar. Briefly, I don't want to spend a lot of time talking about HHS because that's not what we're here to talk about today. But what does the treatment for that look like and how is it different from DK?
I think it's a lot of fluids, and I still think you're probably, I think it's mostly fluids because you're dealing in a hyperosmolar state, but I think with some of these, you're still going to have to give insulin because you need to get rid of the excess glucose. But I am by no means an expert, and I would call my friendly endocrinologist and I would say, please help me. And that's what I think, though. Do you have
No, you're absolutely right. Mainstay of treatment is IV fluids. And if you give insulin, much slower rate, a quarter to half per kilo. And then the goal is to kind of keep that sugar falling between 50 and 100 per hour. So you don't want to like do too fast or too, and they have to be kind of moving their sugar down before you can start the insulin. Just a couple cautions out there. Kids that have HHS are at risk for AKI, rhabdo, VTE, and also malignant hyperthermia, which is interesting.
Oh.
I didn't know that. And then HHS is considered improving or better when the patient, and these patients a lot of times are obtunded, is what I read. They're
that would make sense. Yeah.
Confused or even comatose. But when they're alert and their osmos are less than 315, so that's considered converted. So let's talk about cerebral edema, which is probably the reason why we're here and the most important thing we can talk about today. Let's talk about that.
So cerebral edema is this complication from correction of DKA. It can occur in other things, but that's the context we're talking of it. And it's the biggest cause of morbidity and mortality in patients with type 1 diabetes. And it's more likely to occur in patients with DKA that are younger. And that's probably because those patients are presenting, just like we said, it's hard to identify when they are having problems. So they probably present with more severe acidosis and electrolyte derangements. And essentially, I think the school of thought on this from a molecular level is changing. But what used to be the thought is that our body is trying to compensate with this elevated glucose level, and we have no insulin, and so our body's trying to manage accordingly. So intracellularly, there are these what are called idiogenic osmoles, which is essentially a byproduct that the cell has created to try to draw fluid to compete with the extracellular fluid that has all this glucose in it, right? We're trying to maintain homeostasis. And so if we were to just quickly correct the hyperglycemia. You have all of this excess fluid that all of a sudden is like, I don't need to be hanging out here. There's no glucose out here, would rush into the cell because your body has all these idiogenic osmoles, and then you would have this swelling and the cerebral edema, right? But I think molecular levels are now showing that it's really perfusion injury, like what is seen with strokes. And so it will be interesting to see if this dictates what we change in the future, our management. But right now it is let's correct these things slowly, so that way the body has time to adjust. I think that's.
Yeah, agree. And I guess at one point they were thinking hydrating these kids was causing the cerebral edema to be worse.
Too much fluid too soon.
But what I read was that, like, you shouldn't not hydrate these kids. You know, you don't want to dump gobs and gobs of fluid in them, but.
Right. I mean, a lot of them are coming in super dehydrated, about 10% at least, and they may have kidney injury. And so you have to replace their fluid, and you should feel like you should, but you also know that you may not replace it all right away within the first hour, right? You may be replacing it steadily.
Over time. Yeah.
Right.
So who's are patients that are at most risk for developing cerebral edema? Who falls into that category?
I think the younger your patient, the more acidotic they are when they come in, and new onset, because, right, it just wasn't recognized. So those are the top three things that I can think of.
Yeah.
You have other ones?
No, that pretty well covers it. And one source said, you know, if your kid looks severely dehydrated and they're very tachypnic, and or Kussmauling, you know, you should be really, really concerned about it.
Yeah.
Tell me about, like, onset of cerebral edema. Is this somebody who presents and it's already happening? Is it happening later? When am I concerned about this?
So it typically occurs, I think, within the first kind of 24 hours of your kind of correction of DKA. But I would say if you're seeing someone that's already obtunded on presentation, then the swelling is already occurring, right?
Yeah. Yeah, I guess in my mind, you know, I haven't worked up tons of these patients, but I always thought, you know, they would kind of present that way, and they can. But really, it's during that,
like,
you know, it's during
12 hours. Yeah.
Yeah. What I read was between 4 and 13 hours is when you're most likely to have this occur. So, you know, I mean, I always knew that we were doing these neuro checks on these kids, but I guess it wasn't on the forefront of my mind that, hey, this is actually this is something we're going to see in the ER.
And, you know, you feel bad for these families and these patients because they feel horrible. They probably haven't slept in a while. And then you may be boarding them in your ER while you're waiting on transport or waiting on a PICU bed. And so don't minimize the neuro check that needs to happen. And you want to make sure it's good. So it's every hour, which is kind of annoying for these patients, I'm sure, but it's for their best interest.
Yeah, and if they're boarding with you, don't put them on autopilot and forget to swing by, you know,
right,
when they're most at risk for decompensating in the ER.
Exactly.
Yeah. So how do you diagnose cerebral edema? Like, is there a criteria? Like, what makes a kid have, like, how am I going to know when they're having this?
I mean, in my experience, they're significantly obtunded and they have a significant mental status change, and then you would see it on CT. You know, you would see the effects of it, like narrow ventricles, but you may see vital sign changes, right? Like they may have some bradycardia, they have irregular breathing, agonal breathing. So those things would be signs that this patient is rapidly decompensating.
So it's a clinical diagnosis. You know, you can get a CT, but apparently you don't have to get a CT. But again, if they're altered, you know, we already talked about getting a CT when you have a kid that has altered mental status.
Right.
There is a Muir criteria. I just learned about this yesterday. It's a little bit.
Tell me more.
Well, it's a little complicated. I'll attach it to the notes. But basically, there's 3 sections of symptoms, and if you have 1 out of the top category, you know, you meet criteria. If you have 1 out of the second category and 2 out of the third category, you know, so it's one of those where you kind of have to do a lot of thinking. And it's seemingly pretty reliable when you look at the numbers, but it is a little complicated, and it's not something that's available on like MD Calc. Like I can't whip this out super easy, so I can see why it's not been widely implemented. I was just curious if it was something that you used. So how do we treat this if we see it?
So this is kind of what I was talking about. If there's been an acute change, you want to try and reduce that edema. And so that would be hypertonic saline, or mannitol. And then also you need to think about if they're having irregular respirations, do you need to protect their airway? And this is the population, the ER, where, along with asthmatics, right, we're told never to intubate patients in DKA because we cannot ventilate them as well as they're ventilating themselves in this acid-base status that they're dealing with. And so if you were thinking you need to protect their airway, I would make sure you're having a conversation with an intensivist and make sure that you have to recognize that if you do end up intubating, you're going to have to hyperventilate because that is the way this body has been compensating. And it's really not an ideal situation.
Mm-hmm, mm-hmm. And do you have a preference of the hypertonic saline versus the mannitol?
I personally would use hypertonic saline because these kids are dehydrated and I'm not really looking for them to lose more. But I know that there's some debate amongst different institutions and probably where you trained. Other people think maybe mannitol is better because then you're not dealing with changing the sodium, but it's not a significant sodium change just with the volume that you give. And I'm giving 5 mils per kilo when I give hypertonic saline to a max of 250 mLs, and I give that as a rapid bolus.
Over 15 minutes.
Like I give it push pull.
Oh, okay.
Yeah.
And if they have resolution of symptoms and you're not done giving it, do you finish it?
I guess you could give it slower. Yeah, I would complete the therapy. I think it would be a little bit unusual for them in the middle of giving that bolus if they just all of a sudden were to perk up, then I would say then it probably wasn't cerebral edema. But yeah, I would finish it.
Do you ever repeat it?
I have given another hypertonic saline before in another case of it was not cerebral edema and DKA, but yes, I have repeated it before.
Yeah. Interesting. All right. Common complications we see with kids in DKA. Can you think of any?
So complications, you need to look for what put them into DKA. And so it could be an illness. It may be that they have the flu when they're coming in, a UTI in girls. I would always check for pregnancy in an adolescent female. Patients with diabetes can have other medical problems. So it could be appendicitis. A lot of these kids come in and they're complaining of belly pain, and most likely that's from the ketones, right? But it doesn't mean they can't still have a surgical abdomen. And then, there is, in the state of DKA, they are going to have this theoretical, this possible hyperperfusion injury. And so they, repetitive instance of that can affect, your cognitive function. But I would not expect to see that, after just one time. But I would tell the family, yeah, your child's going to feel pretty horrible for a while, and they may be exhausted and need time to recover.
Yeah, an interesting aside here, fun fact. One of the things that was mentioned in the literature is considering mental health complications, which I don't think comes to mind for me very often. But sometimes diabetic girls know that if they,
yes,
that they can
and
lose
they may
weight.
learn that they may learn that at diabetic camp, or you may discover that they're doing that at diabetic camp. So it's, females that don't have diabetes and do have diabetes are, and males too, but historically we associate it with females having some, body image or wanting to fit a certain expectation. And they recognize that if their blood sugar is high and they're not taking insulin, their body will start to metabolize fat. And so they may intentionally withhold insulin.
Yeah, I thought that was fascinating. I haven't run into that yet, but
yes. And, if they're on an insulin pump or they're an adolescent, right, a lot of parents are trying to step back and let their teenager have autonomy. And I think that's when we see a lot of presentations of DKA in established patients, is when they're trying to take ownership. That can be tough. And it usually will catch the parents off guard because they didn't know that, she wasn't taking her insulin, or she's been not correcting, even though her insulin pump is telling her you should be taking insulin.
Yeah. And on the opposite end, giving themselves too much insulin. And we had this happen pretty recently. It was an adolescent male, I think, that
Right.
was taking too much because he was suicidal and
Yeah.
didn't want to live anymore. So.
Yeah. And I mean, you have to recognize that insulin is powerful and it can be lethal if you take too much of it. Right. And so I think recognizing that families are really need to understand like how powerful this is and need to understand that, you know, if their child is not acting appropriately, you have to check a blood sugar. And so there is a lot of fear, or, you know, you may have some diabetics that had a really bad low blood sugar. And so they're really hesitant to take insulin because they remember what it felt like. So they prefer for their blood sugar to be high because they feel better and they are avoiding that hypoglycemia that was felt near death to them. So there's a lot of nuances to it. And yeah, just it's probably multifaceted why that patient is coming in and in DKA.
For sure. You know, in adults, a lot of adults allow themselves to live higher because they feel better. Is that true in children too, would you say?
So I would say it's all based on what you're used to. So if before you started taking insulin, your blood sugar was in the 300s, and then all of a sudden we give you a slug of insulin and your blood sugar hits 80, you are going to feel jittery and low and sweaty and feel like you're about to pass out. And so it takes a while for your body to reset and to feel what the new normal is. And so you have to recognize that's what they're feeling. Their body has responded to what their normal is, and their normal needs to be what a non-diabetic is, but it's going to just take some time. And as someone starts to take insulin and gets more used to having their blood sugar within range, then they'll start to feel horrible when their blood sugar is out of range. Mm-hmm. But right now they feel horrible when their blood sugar is low because they feel like they're going to pass out, and they're going to be reaching for Powerade when their blood sugar is 200 because they're used to 400.
Yeah.
And so the perspective of it is important.
Yeah. So how do we disposition these patients?
Yes, well, hopefully they're in the PICU and they correct them and then they go home. But the reality is, especially in established patients with diabetes that are in DKA, you may correct them because they may be waiting for a long time. So essentially, you need to get their bicarb over 15. I don't routinely keep repeating a VBG because as their bicarb improves, their pH should improve, right? So I'm not repeating that. And they need to be able to eat and have their insulin to correct and feel better. So typically what we do as their bicarb goes over 15, they start to feel better. And then if they are on an insulin pump or they need insulin pump supplies, I would have a family member go home and get that. So that way you can be prepared to set them up. And then you let them eat, you take them off the insulin drip, and you correct for what they ate. You correct their blood sugar, and then they should be able to go home. You know, if you're at a outside facility, I would touch base with their endocrinologist, and you just want to make sure that the patient has ideally the resources they need to be able to not go back into DKA. And you may not be able to control that, but you don't want to discharge someone if they don't have insulin at home.
Right.
You have to figure out, otherwise they're going to be right back. So you may need your social worker involved or may have to figure some of those things out. And a new onset diabetic, you're not sending them home. They need diabetes education and they need the endocrinologist to help determine what their long-acting insulin is going to be, diabetes education, so that way family knows how to keep their child safe.
Yeah. But if they're new onset, not in DKA, they could go to the floor, right?
Mm-hmm. Yeah.
And for us, PICU, if you're in DKA, you're going to PICU. Obviously, if you have cerebral edema, we have bigger concerns. Right. You're going to go to PICU.
Right.
But yeah, sometimes they go home. So is there like a time frame they need follow-up after if we're discharging them home? Let's say we've converted them.
I would say, you know, probably in an ideal world, they would all get follow-up, but that's, I think our medical system and our subspecialists are probably in high demand. And so I don't know how realistic it is to expect that they're going to follow up with an endocrinologist in, you know, a week or so. I would always touch base with an endocrinologist and see if there are any changes that you need to make. And then I would also try to do your best to understand why they ended up in DKA. If they have an illness, then you need to tell them, okay, you may have to check your blood sugar every 3 hours and correct every 3 hours because your body has this degree of insulin resistance right now. And so you're going to need to take more insulin while you're sick. If they came in because they were vomiting, not from ketones, but couldn't eat anything because of a stomach bug, you want to make sure they have Zofran. So you just want to make sure you're addressing the whole reason they got into DKA, at least to the best of your ability. And for some of those, there's social issues that we can do our best to help, but I don't know if we're going to always motivate the 15-year-old to take his insulin at night, if there's not buy-in from the patient and family, which is, frustrating.
Yeah. I was thinking about this last night, like what do we tell these kids to follow up? But what I've seen in our own endocrinology is that these people communicate with the endocrinology department pretty regularly, Yeah. So it's not that, they necessarily have to have a face-to-face in 2 days, but if they are established with an endocrinologist, they're probably communicating with their diabetes educator and, certainly
my chart.
Yeah. So there's definitely communication if they're plugged in, and if they're not plugged in, they're getting admitted so they can get plugged in.
Right, exactly.
So I think you kind of started talking about this, but tell us about what a sick day regimen is. What's funny is I've only heard this term once recently, and I didn't know about this at all. So you're the perfect person to tell us what that is.
Yeah, so a sick day, it just means like, how do you manage your diabetes when you're sick? I mean, I think most patients with type 1 diabetes, they should have Zofran at home, because if you have low blood sugar and you're vomiting, like you've got glucagon, but you have to figure out a way to be able to consume something to raise your blood sugar. Most of the time when you're sick, you're in a state of insulin resistance, and so you need more insulin. And so frequently, if you're on an insulin pump, your endocrinologist may tell you to do certain things. If you're on an insulin pump, you can increase your steady state of insulin or your basal rate by 20% or 30%, and you can just type that in and say for how many hours you want it to be done. And each insulin pump is different. If you do injections, I think frequently they'll just tell you to check your blood sugar every 3 hours and correct every 3 hours. They may tell you to go up on your Lantus, but usually they'll just tell you to change your fast-acting insulin. And they'll tell you to do that as long as you're sick, because your body is experiencing stress.
So
or if you're on steroids.
It's set up by the endocrinologist with the patient, kind of tailored to them?
Yeah.
Okay. I had a patient with this the other day, and she was telling me on her sick days she checks her ketones with a strip like every 2 hours or something. So
and patients, or at least what I've been told, is that if you have 2 blood sugars greater than 250, you should check for ketones, and families should have urine strips, or now families have, I think, glucose monitor, their beta hydroxybutyrate blood monitors, and that they should check. And if they're on an insulin pump and you are having persistently elevated glucoses, you should change your insulin pump, because you may have a pump malfunction. And frequently it's the cannula, which is that little plastic tube that just goes under the skin. But all of these patients with diabetes, they have scar tissue from where they've been either administering their injections or their pumps. And so it's possible for that cannula to get kinked. It's possible that the cannula came out if someone was doing a lot of activity or they were sweating, but the pump still is adhered to the skin because of the adhesive. And so frequently you're taught to troubleshoot and figure out how to, make sure it's not a pump malfunction. Other complications can be your insulin can freeze. Like if your insulin gets too cold and becomes cloudy, it's not good. If your insulin gets too hot, it's not good. And so, you may need to use a new vial of insulin to see if it was just your insulin went bad. And so those are all things that I usually ask someone when they're coming in DK and we're trying to figure out if they can't identify a reason. I'll try to kind of problem shoot with them.
Oh, that's great. I've never asked those questions. So awesome.
Yeah.
Okay. Well, here at the end, I just wanted to go over some of the highlights and just see if you had anything else you wanted to add here. So our highest risk kids that come in for complications of DKA and also developing cerebral edema are those really young kids, typically less than 5. are kids that have new onset diabetes or prolonged symptoms, and that's going to classically be your new onset because they're undiagnosed. Right. I know this is one that you harp about all the time, Whitney. Kids that come in with vomiting, AMS, they're lethargic, check a blood sugar, right?
Check a blood sugar. It is so easy and gives so much information.
Yeah. And I know you like to add a urine too. I mean, we're getting urines on a lot of these kids anyway, so so easy to do. Mm-hmm. Yeah. First step for management of DKA and HHS is IV fluids. Start there. Get your labs. Your insulin will start in a little while. I always have to remember to simmer down. You don't have to do it all at one time. Check their blood sugar every hour while you're on insulin and insulin drip. Mm-hmm. How often do you monitor electrolytes once you get started?
So I think a lot of institutions have it kind of protocolized. I think we repeat our BMPs like every 4 hours. And I think that's reasonable. Now, if you have something that's really abnormal, like a really low or really high potassium, I would check that more frequently with an iStat. I would do that until it's within a more normal range and you're not seeing side effects. I would probably do that hourly. But otherwise, I think 4 hours is fine.
Yeah, yeah. And all the guidelines say somewhere between 2 and 6 hours. So perfect. Look for what the underlying causes of your DKA. So don't forget to do a good physical exam. Look at their skin. Look for wounds. Look for anything that might give you some clues as to why they're here. We talked about avoiding intubation and why. Two other things to absolutely avoid in this group is bicarb administration.
Bicarb. We didn't talk about that.
I know.
And it's interesting. We didn't talk about it. These patients are acidotic, but we have to remember why they're acidotic. And just because they're acidotic doesn't mean we should just give them bicarb and like fix that pH. It will change the respiratory function that the body is doing, is compensating. And so it may lead to worsening respiratory status because they're not going to be taking these nice, rapid, deep breaths. And I've never given bicarb to any of my patients in DKA. I think it's reserved for very special populations. So if you're maybe having some cardiac dysfunction because the body is so acidotic, that I could see an argument for that.
CPR.
Yeah, exactly. And then anecdotally, I had a colleague who had a patient in DKA that had a solid organ transplant. And the transplant team asked for them to give bicarb because of the organ transplant. So I think, you have to take each patient into consideration. But by and large, do not just give bicarb.
And then also avoiding central lines. We don't do that very often, I don't feel like.
Yeah, I don't do them, so
yeah.
I'm avoiding them.
Yeah. All right. All right, be on the lookout for pancreatitis in particular. I don't routinely get lipase on these kids. Do you ever check a lipase?
I don't, but I guess, if you're having someone that's having really significant vomiting and it's not getting better, like you're like, man, why is their nausea and belly pain not getting better after their ketones are diminishing? Yeah. I would say, yeah, that's worthwhile checking.
Or they've got really severe upper abdominal pain.
Right, exactly.
Sepsis, we talked earlier, you haven't had one in sepsis. I haven't either. But obviously infection of any kind can land us
And you just think, bacteria, fungal infections, they all love glucose. And if you're in DKA, you've got a lot of it. So kind of a good breeding ground.
Yeah. Always looking at the creatinine. They commonly have an AKI with DKA, sorry. Even renal failure, VTE, we mentioned rhabdo, and with the HHS in particular, potentially the malignant hyperthermia.
Yeah.
With cerebral edema, it's a clinical diagnosis. Treat early. You're going to pick mannitol or hypertonic saline. I know you prefer the hypertonic saline.
Right.
And then we put them in the PICU.
Yeah.
All right.
That's right.
I think we did it.
I think we did it. DKA, it's so easy.
So easy, yeah. This is probably the podcast I fretted most about and read the most about.
It's kind of, I would say like every institution, is protocolized. And so if you're going to transfer to a certain institution, you can always ask the transferring center what they would like you to do. Some places don't want outlying facilities to do anything other than give a fluid bolus. Some outside facilities, they would be okay if you start an insulin drip based on our requirements. But if you're at an outside facility, just reach out to your referral center and don't be afraid to ask questions and be specific. If you ask specific questions, you're going to get specific answers, and they can really guide you. And then if you're concerned, just say, I'm very concerned, and that will resonate with the provider that you're talking to like guide you and try and help you to take the best care of the patient.
Yeah. Yeah. We're, always open to questions from any provider that calls with anything. I think, we're happy to tell you what all the labs to order are and just take good care of the patient. So,
yeah.
All right. Thank you so much for being here. I appreciate your time.
My pleasure.
All right. Well, have a great afternoon.
Okay. Bye.
Thank you so much, PEM Chat listeners, for being here with me today to talk to Dr. Whitney Buss about all things DKA. I appreciate your time, Dr. Buss. Thanks for being here. Now, join us next month when I'm going to sit down with Madison Matthews. She is a certified child life specialist, and she's going to talk to us about what that is, what it is they do, and how we can implement some of the things that she does into our future patient care experiences, really to make it better for our pediatric patients. I look forward to seeing each of you then. Any opinions expressed on today's podcast are solely those of the speaker and do not reflect the opinions or policies of any employer or hospital system. In many states, advanced practice providers work collaboratively with physicians. One should always be careful to consult with your physician leader when it's appropriate. This podcast was designed for medical education purposes only. Its speakers have made every effort to provide the most current and evidence-based information. However, that should never replace one's own effort to validate current evidence-based practice before implementing a plan of care. Any pathway or algorithm that we may have discussed may not reflect those of your healthcare system. Please be aware that these may change based on your geographic location or current employer site. This podcast was not designed in any way to provide medical advice or treatment plans for patients and their families. If you have a medical concern or an emergency, please be seen by a local medical provider or call 911 for assistance.